was sizzling a little bit on Friday afternoon, so we'll go through a little bit of a review of what we covered then and start from here. Today's gonna be another mostly anatomy day, and then tomorrow we'll hit some physiology as far as like filtration pressures and such. But, so globally, for the vessels that we talked about on Friday, right? We're gonna skip past all the components of blood. You guys got that, fluid compartments, we've done that. But, just generally, what was the, when we have arteries, veins, right? What was the one thing I said about arteries? Elastic, right? Elastic. On the artery side, we have the thinner outside layer, then we have the really thick in the middle layer, the tunica media, right? On either side of the tunica media is the external and the internal elastic lamina. And in the larger arteries that have more elastic, we have more elastic lamella, even more layers of elastic in there, right? So elasticity, and why? When you pull back, they absorb the blow, if you will, of the ventricle squeezing. They expand. That potential energy then becomes kinetic energy to move that blood forward, right? In the initial part. Veins, on the other hand, what do we talk about there? What's the material? Not elastic, but collagen, right? Collagen. And which layer on the veins is typically the thickest? The externa, the outside layer, externa or adventitia, right? Everything here should have a couple of names. Remember I said, in general, because of that big, thick, muscular media layer of the arteries, the lumen of around, it's the same size vessel, right? Artery, vein. The lumen of the vein is generally going to be larger to accommodate more blood, right? Does that make sense to everybody? And we're going to talk about that on the vein side today. We're going to hit the veins a lot today. We call the veins in the venual system sort of capacitance vessels, or reservoirs. They hold a lot of blood. That lumen is a little bit bigger, okay? So, thickest layer of the artery, the beefy middle layer, thickest layer of the vein, the outside layer, collagen, veins, elastic arteries, right? Now, on the artery side, that's where we focus mostly. Those first arteries, the bigger ones that are closer to the heart, what are they called? Huh? Conductive, yes. And what else? Elastic. Both of you are right, exactly. Get it. Conductive arteries and muscular arteries. And then when we get to the arteries that are farther away, the next branch, the next level of them, what are they called? Huh? Distributing. Muscular arteries, right? You got it? So conducting blood away from the heart and then distributing out to the rest of the body. Remember, there's no clear delineation histologically. If you were to look at a section of this artery here and it's an elastic artery, there's not a clear border where it switches to a muscular artery. It just kind of gradually changes, right? All right. Then, let's see. We got to the arterioles, right? So, arteries, arterioles. What's smaller than that? What's the next step after arterioles? Medarterioles. Before we get to the capillary bed, right? Before we get to the medarteriole, right? And on that arterial side, like the flowing into the capillary bed, on that side where the arteriole hits the metarteriole, there is just smooth muscle. There's no actual sphincter or anything like that. But on the other side, the medarteriole capillary side, what is there? What is that little thing called? Precapillary sphincter, right? Precapillary sphincter, which is just a ring of smooth muscle, and its main function on that precapillary side is to do what? Resistance. What are the arterioles are the resistance vessels. That's where we really increase our systemic vascular resistance, or we decrease our systemic vascular resistance based on if they are open or closed, right? All right, and then we have this one highway, I can't remember, somebody over here said it, that goes straight through all the time. What is that one called? The thoroughfare channel, right? Because we can't have a period at which there is tissue, no tissue perfusion whatsoever. Like a complete absence of blood flow would be ischemia. Ischemia becomes what? Necrosis. We have to have blood flow, even if we're at rest. You guys are all sitting down right now. Even though your legs aren't working very much, you're still getting blood flow to those lower leg tissues, right? So, we have to have that blood flow. Then, when we stand up, we need to clamp down, and we need to make sure we get blood into this thing and not have it pool in our butts, right? Let's see, what am I doing here? Now, I had started the presentation like I had intended to, you would be seeing this. This one I got a few questions about. I want to make clear, back pressure doesn't mean back flow. All right, when we clamp down those precapillary sphincters, which are those little black circles, when we clamp those down, we create a back pressure in the system. It's like we were kinking off a hose, but we don't get backwards flow of blood. Does that make sense to everybody? Okay, yes, sir.
Is there anything different with blood that goes through the peripheral channel? Like, is it efficient?
No. There's nothing, it's the same blood. It's just, is it going to distribute out through this capillary bed, or is it just going to go straight through? There's nothing unique about that blood. It's all coming from the same place. Okay? Yeah. So, got it. Right? And this represents the capillary bed that we were talking about, right? Arterial, and then remember that meta-arterial is just that little connector that goes between the actual arterial and the capillary bed itself. Okay? Any questions about that stuff? Yes, sir.
Sorry, can you say what you said about the lumen size differences again? I think I either
Probably
heard it
not.
wrong.
You have it on recording because I can't remember what I talked about.
So it was not the size.
I'm just kidding. No, I got it. I'm talking about if you have it, actually, you know what, there's a good picture of it. Let me go back to one of these. Sorry, I have to make myself laugh a little bit. There you go. So if you look at this, let's say they're about the same size. The outside, the hose is about the same size. One's an artery, one's a vein. This one has a relatively smaller actual lumen of the vessel because it's got this big, thick muscular layer here, versus this one that has a much larger actual space for the blood. The lumen of the vessel is actually larger, even though about on the outside, they look about the same. And it's basically because of what the arteries have to do versus what the veins have to do. The arteries have to propel the blood forwards. They need all of this elasticity. They need all the muscle to make that happen. The veins just really have to hold it, you know what I mean, and get it back to the heart. Does that make sense?
Yes, I think I just heard that.
Okay. No worries, no worries. All right. All right. Any other questions? Okay. I hope if I make those little stupid jokes, it doesn't come across like I'm picking on it, but I just like to make myself laugh.
I was
All right.
just
All right.
focused on, I think I had this backwards.
All right, good. Please, ask questions. I will probably use there will be some sarcasm, some deadpan delivery. A lot of RBF in this class we haven't, so this is just my face. I promise, I take questions, all right? So, here we go. Capillary system. Now remember, we're still on the front side, meaning blood pushing away from the heart, right? Blood still is oxygenated. We're thinking about this globally, right? Don't talk about the pulmonary artery, whatever. We're still delivering oxygenated blood, nutrient-rich blood to the tissues, and this is how we do it. What the hell? When were you guys going to tell me that wasn't enough?
Oh, you had plans.
You know what? You get no respect, right? I would have just stayed up here for the whole time and not talked about it. Like, what? Oh, shit, you guys are just looking at my home screen, sorry. All right, capillary. So we're still oxygenated blood. And what are we doing now? We're getting from really thick-walled vessels that have a lot of pressure in them to thinner and thinner and thinner. And now we are really talking about 1 to 2 cell layer thin blood vessels with a relatively low pressure. Because why? What's happening here? Oxygen exchange, carbon dioxide removal, waste removal, and nutrient delivery, right? So we don't have, if you think about that slide actually I just put up, that kind of diffusion or transcytosis or whatever you have, active facilitated transport is not going to be able to happen efficiently through that much of a wall, right? We just need 1 or 2 cell layers so we can just send that oxygen, send that glucose, send that whatever into the tissues where it needs to be. And we can also grab all that waste product efficiently while that blood is just trucking right through. Okay? So that's why we have a really thin layer here. All right? Let's see here. This seems like a minor point, but as you guys move forward, there are avascular tissues. Anybody? I'll give you one here. Who's heard of either saddle nose deformity or cauliflower ear? All right, cauliflower ear. That's something that, you know, watch UFC, you see the guys with the weird, like the Randy Couture ear, you know? You know why that happens? Huh? It all boils down to because there is no direct blood flow to or within the cartilage itself. The cartilage is fed by direct contact with the vessels in the skin of the ear. So when they get that hematoma, that blood accumulation that forms between the skin and the cartilage, it pushes the blood vessels that feed that cartilage away from the tissue so it can no longer receive oxygen or get rid of waste products. So if you don't go in and cut that and evacuate it so that you can put that skin back in contact with the cartilage dies and you get radicoturia. So avascular tissues are important to know where the avascular tissues are so you can understand what's important. A punch in the nose seems minuscule, right? And if you were to go to look in there and you saw blood in between the septum and the cartilage skin, you'd be like, well, that's not that big of a deal. You just got punched in the nose, everything's fine. But if you don't evacuate that, you get the same thing in your nasal septum, which is a piece of cartilage only fed by the tissue that it comes in contact with, and then you get this weird, deep saddle nose deformity, right? And so cosmetically, it's a life-altering thing for a patient if you don't know that that is actually kind of a big deal. You know what I mean? Does that make sense? So just knowing sort of where tissue is avascular, where it has good blood flow is really important, all right? So, small, doesn't matter how small, no, I'm not gonna ask you how many micrometers something is thin, it doesn't really matter. It's all academic, really. The takeaway is that it's really thin, and that diffusion, that transport of the nutrients can happen efficiently because of how thin that membrane is, all right? There are approximately how many billion capillaries? Question number 1, 19, 20, 21, 22. All right, so there's a picture of how small they are. So red blood cell size, as you get down to a single, membrane where you have enough space for a blood cell, right? So again, all of that rich oxygen that the blood is carrying, all of the nutrients are diffusing nice and easily through that membrane into the tissue. 3 main types, all right? They all have these same layers, but the layers are going to be constructed differently based on the area of the body, the tissue of the body that they're perfusing, that they are intended to deliver stuff to, all right? So the capillary bed, the point isn't that it's 10 to 100 capillaries, the point is that the capillary bed, now we're talking about that middle part, all right? So the arterial, the meta-arterial, now we're in that capillary bed, we're in that middle piece, all right? The webbing, if you want to call it that, from what it looked like on the drawing, all right? And this is what I had talked about just earlier. Like when you're at rest right now, most of the precapillary sphincters are going to be diverting blood through the actions of the precapillary sphincters. They're going to be diverting a lot of the blood, keeping areas perfused that need to be perfused. So again, take your lower legs right now. Your lower leg, not very metabolically active right now because you're sitting down. So where are we diverting our blood to? Your brain, your ears, your eyes, even to some of you who are taking notes, your hands. You see what I mean? So we're just keeping the tissue that's being used active and perfused, all right? Vasomotion now is an important concept. That opening and closing of the precapillary sphincter is what creates vasomotion. And break the word apart. What does it mean? Vasomotion. Vascular movement, right? Vessel movement. And that's what it is. Movement of blood through these precapillary sphincters into the capillary network, and then out the other side to the post-capillary venule, which is something we haven't talked about just quite yet, all right? And that opening and closing, that cycling of the blood through the tissues, through that capillary bed, is modulated by, look at the bottom, right? The local chemicals released. Oxygen level, what do we talk about mostly? One of the primary functions of blood is to do what? It's a connective tissue because it connects the oxygen to all of the tissue. So the oxygen delivery, carbon dioxide level, right? Lactic acid, hydrogen. So anybody who's had, I know this is probably a little bit more advanced, but anybody who's had any experience with medicine before, does anybody tell me what carbon dioxide, lactic acid, and hydrogen ion increase would have in common? It'd all be metabolic acidosis. It'd all be causes of acidotic pH, so a lowering of the pH of your blood. Carbon dioxide, when we start to talk about acidosis and alkalosis, carbon dioxide is one of the primary ways that acid is transported in your body. Hydrogen ion is acid, H+ is acid, pure acid, and then lactic acid is a metabolic waste product. Everybody's heard of lactic acidosis. Everybody's felt burning in their legs when they run. That's lactic acidosis buildup, okay? So all of those things, and none of that extraneous stuff is important, but what is important is that this is locally the chemical signals that's telling I need more blood and more oxygen to the area, or we can slow it down, we're good, right? How much oxygen do I have? How much waste product am I accumulating, right? That balance is essentially what keeps that basal motion moving and what tells you, well, this area of, you know, I'm sitting down, my legs are good. Oh no, now he's standing up and walking, he needs more blood, more oxygen, more nutrient to that muscle. Does that make sense? Kind of on a basic level? Everybody? Yeah? Go ahead. All right, types of capillaries. These are the ones that we have mostly everywhere, continuous capillaries. They have, if what you're going to think about with these two is the size of the hole in the vessel, all right? These are continuous, meaning the size of the space between the individual endothelial cells is very small, right? Continuous. It's like a straw, right? Not exactly, but you get it, right? Conceptually, just think about it that way. So, let me go to the next slide and show you. So these intracellular clefts, right? Intercellular, meaning between two adjacent cells, is very small, right? There is a space because don't forget the overwhelming reason why we have capillaries is to deliver oxygen and nutrients and stuff. But the space is very small, okay? And it's because functionally, where these are in the body, they need to be small. We're just dropping off oxygen, picking up carbon dioxide, and moving along, all right? When we get to the next couple, you'll see that functionally where they are, they have different responsibilities, all right? Does this make sense to everybody? And you see, basement membrane, endothelial cell, that's it. Basically, 2 layers thick, really thick. All right, next one, fenestrated. What's a fenestration? A hole. Think of these like a sieve or a colander, right? Have a little bit bigger space because they're in places where they have to do different things. All right? They need to be able to pick up larger molecules and exchange them. All right? So, if you look, these very important ones are in the kidneys. Now, prelude, you don't have to write any of this down. Just know that they're, right now, knowing that they are in the kidneys is good enough. But in the kidneys, we've got to exchange some proteins. We've got to exchange some larger molecules. We've got to exchange some cellular material as far as waste and diffusion is concerned, okay? In the villi of the small intestine, does anybody know what's happening in the villi of the small intestine? We are absorbing nutrition. We are absorbing carbohydrates. We are absorbing fats. We are absorbing proteins, right? And so those are large molecules that have to have the space to get in and get out. Does that make sense? So why they're in different spots is going to be the difference in the structure. The difference in the physiology is the difference in the anatomy, if you will, okay? So fenestration, see? Like I said, bigger holes. They still have those intracellular clefts, but they also have these guys. Like I said, a sieve or a colander, all right? Everybody know what a sieve and a colander is? Yes? Let me see. Did it say intra? No, that should be inter. Yeah, you mean this right here? Yeah. No, that is a mistake. Good catch. That should be inter. Yes.
So are the intercellular clefts any larger
No, not generally. Like, when we get to the next one, we have sinusoidal, they're gonna have these huge spaces in between, the cells are literally spaced out differently. Not really, maybe a little bit, but the main driver of the difference in the physiology are the fenestrations, yeah. Thank you, by the way, I appreciate that. If you guys see mistakes, do not hesitate, I know for sure I'm dumb, and I need help. No, I'm serious. Like, I barely graduated high school. So, sinusoid. Sinusoid, what does it sound like? Where is the sinus that we've already talked about? That we've already talked about. Coronary sinus, yeah, that's it, right? And what is a coronary sinus? It's just a big open vessel that allows a lot of stuff to jump into it. Think about a sinusoid. Now these, as we were talking about back here, we have, very wide spaced out cells. And this is because in the places that these are found, we need to have huge molecules moving back and forth. A lot of times we're talking about albumin is one of the primary ones here. And albumin is a big, huge colloidal molecule. So if you had to guess where a lot of albumin movement might be happening based on where albumin is made, does anybody know? The liver, right? The liver is the spot where you're going to find sinusoidal. And then you say sinusoid or sinusoidal, like I said, depending on how they reference, it's the same thing, all right? Same thing. Does that make sense, everybody? I know it says sinusoid here, and I've been saying the other word, but it's the same. Very large, and this is what, back to your question in the back there, these guys, again, the cells are like just way far apart. Yeah. Okay. So, liver, okay. Anybody want to guess, hazard a guess, a function of spleen? Clean. Does everybody know what a senescent cell is? Does anybody know what a senescent cell is? So it's like an old dead white blood cell, one that has run its course. So one of the things in the liver and the spleen is to remove senescent, old, dead, waste, no more at the end of their life, red blood cells, to recycle them, grab their hemoglobin, put them in a new cell, and send them back out to their fight, right? That's part of what the thing does. And so red blood cells, we all think of them as very small, but when you compare a red blood cell to an oxygen molecule, it's very big. And those things have to move back and forth out of the sinusoidal capillaries. Does that make sense? So functionally, that's why they have such large spaces in the places that they're found, is because larger material has to move inside and out of it, all right? And so you see, these ones have big holes in them. Looks like they got shut up, right? So not too bad. All right, and then in the places that we've just been discussing, have something called a portal system. And without getting too deep into it, because we'll talk about it a lot in the GI section, a portal system is basically a way to divert blood into another capillary network before it returns into systemic circulation. And conceptually, the easiest one to think about is this one right here, the hepatic portal system. Some of you may be familiar with it, but for those of you who are not, the hepatic portal system, okay, think about it this way. I've already talked about blood vessels, right? So arteries go to our GI system, right? Our gut, our abdomen. Splanchnic circulation is what it's called. What is happening? What is, so as we're delivering stuff to there, what is also being picked up in the abdominal system? Like, what are the veins going to be carrying that immediately branch off of the lower intestine, the small intestine? Nutrients. All the nutrients from digestion. Exactly. And so that is returned, instead of going directly into the vena cava and then directly into systemic circulation back around, it goes into the hepatic portal system. So it goes into the hepatic portal vein, into the liver. And what is the liver able to do? Help clean the blood of any waste products that don't belong there, help phagocytize any dead cells, and also help collect and store and distribute some of that nutrient, right? So, and then from that portal system, we go back into the vena cava and then into systemic circulation. So again, a portal system that kind of diverts for a function such as that, and then back into regular circulation, all right? And we'll talk about that at length again, just so it's a prelude to what a portal system is. Does that make sense? Maybe? Okay. So again, if you see, this is the liver, this is what's called the splenic circulation, all right? So all of these vessels are returning all of this very rich blood into this large hepatic portal vein, where then it's distributed and then it makes it back out through the hepatic veins and back into systemic circulation, right? So the blood vessel at the bottom of the liver is the portal vein. The ones at the top entering the inferior vena cava is after it's done through the portal system, okay? Okay, any questions? You don't have to, just so you know, I like to keep everybody on the same page. You don't have to really worry too much about the portal system and the long description of the hepatic portal system. Just understand what a portal system is and what it does, okay? When we get to the point we're gonna be talking about it, we will dive into the hepatic portal system ad nauseam, all right? Any questions so far? No? All right, so we are past now the point of delivery. Okay, we're on the capillary bed, and now what are we bringing back? Deoxygenated blood back to systemic circulation, right? So we are past the capillary bed at the post-capillary venule. So the first site of our venous blood, if you want to think about it that way, all right? These also allow us, where is my whole guy? There it is. This process called diapedesis. So these have a bit more porous walls than the capillaries themselves, sort of allow white blood cells to do their function, right? And if you think about it, if you have a site like just a skin wound, right? What does that skin wound need? What do you need to heal? Initially, you need oxygen and nutrient. And then you also need white blood cells, the inflammatory markers, to come in and help create that healing of the tissue, right? So that's why this area has a little bit more porous tissue, right? Oh, this is a little, most of our metabolic exchange has already occurred. But because they are still very thin-walled vessel, you can still get some exchange. And I want to say, when I say on this side, metabolic exchange is mostly the removal of waste products rather than the delivery of stuff. All right, so just think of the post-capillary side as waste removal, right? But some exchange still does occur here. So a minor point, but important enough to make a point of it, all right? Make sense? Yeah? Okay. And so we go muscular venules, and they, as they move away, they gain more layers. Think about it that way, right? They go from thinner to thicker, so they gain more smooth muscle as they sort of move away. Does that make sense? If you're coming from the capillary very tiny, you move your way out into the vena cava, the walls are going to be thicker. That's an easy way to think about it, all right? But, like I said, we're talking about capacity on this side, all right? So most of our blood volume at any given time is going to be in our veins, in our venous side of the house. So they accept capacity. They can be reservoirs of blood as necessary, right? And then that reservoir, when we turn it on, we stand up and we start moving, we start to move with that systemic increased pressure, and we move that blood back into kicking into systemic circulation. So we started from the heart here, we worked our way down through the capillary bed, and now we're going back to the heart this way, right? Yes, sir.
Is this kind of like the idea where like bed sores come from, like not getting back up in those venules, not being able to push blood back up the circulation system?
That's a long answer, but I'm going to say yes, because essentially, when you get to that point of pressure ulcers and bed sores and things like that, you have a lot of incompetent blood flow, because you have a lot of, it's stasis ulcers are what those are called. So it's not necessary, they're not moving blood efficiently back. We haven't talked about it yet, but we have a thing called the muscular pump and the abdominal pump that help literally pump the blood back up, because there is a very low pressure in those lower limb arteries, or vessels, veins. So if you're static for long enough, one, you have reduced blood flow because you're old and infirmed or you're very, very sick. Now you don't have the muscular movement, so you get blood pooling. And yeah, these little tiny pieces of smooth muscle are not enough to efficiently move all of that blood back, so you get that blood pooling and then you start to develop ischemia because you're not getting a removal of waste products. So, long answer, but yes, kind of.
Gotcha.
Does that make sense?
Yes, sir.
Okay. Alright, so again, what did I say? No elastic. Alright, what's on this side? Not elastic, but collagen. That's right, you guys. Alright. Capacitance, right? They have that bigger lumen relatively. They can hold all of that blood as it's making its way back, right? It doesn't come back to the heart as fast as it left the heart, if that makes sense. Much lower vessel, right? Pressure, that, you guys have seen that before. You guys have seen in real life, in movies and what have you, live tissue labs, blood exiting an artery exits significantly faster than it exits a vein, even a large vein, okay? So it just has to do with the pressure. We're gonna talk a lot about those pressures in the vessels towards the end of this block of instruction, all right? So again, back to this same, on the artery side, very heavy muscular wall. On this side, very thick outside wall, okay? And this other thing that we're about to discuss are these valves, all right? Not gonna be found in arteries, but they are gonna be found in our veins, okay? A lot, and I'm talking about the lower legs a lot, but it's just, if you wanna think literally, gravity is not our friend here, so these help prevent a backflow, help prevent stasis. They are actual folds of the tunica interna, so or the intima, whichever one you want to call it. And just like the cusps of, say, the aortic valve, right? When blood flows backwards, it catches the cusps and it kind of keeps them together with that same sort of gasket effect, like I talked about, right? So there are no papillary muscles or anything holding these closed. They close through the weight of the blood that falls back on them, right? And these aid, and again, retrograde blood flow. There is retrograde flow, but what they do is they keep it in a certain area. And then when we start to add on the muscular pump, that helps get that blood flow back. Imagine if you didn't have them, you would have a significant amount of, you'd have to have a much higher force to overcome to get that blood back in. If you didn't have these little stopgap canal, or dams, if you want to call them, okay? If we're getting, somebody's gonna have to keep me honest, because I always lose track of time, so when it's time for break, just let me know. So if you look at these, again, not super thick, just cusps, flaps of tissue of the intima. All right. And this is a very good example of basically of a lower leg vein. And again, we don't need it as much in the upper legs, on the upper limbs. We do have them, we don't need them as much. But what we don't see, we haven't talked about yet, is again the muscular pump. So imagine that's deep underneath your calf, underneath your gastroc, between your gastroc and soleus. Every time you take a step, it helps squeeze that blood up. So we have that assistance there. And then those cusps serve to not let that blood fall back down too far, all right? And we've talked about it already, and it's in the clinical correlations today, but what happens if those valves become incompetent or don't do their job? You get blood pooling, you get edema, and you get varicose veins, those big, thick, blue veins, so you can see. Vascular sinuses, we've already discussed. The coronary sinus, of course, is not the only one, but it is one that we have discussed, so it's an easy one to pick out. Just a big vessel that drains smaller vessels, so, tributaries flow into the coronary sinus, and then that flows into the right atrium, yeah. Now I wanna call your attention to this right here, because, of course, we start with the multiple nomenclature. So you might see these called perforating veins, you might also see them called penetrating veins, all right? Just understand it's the same thing. And basically are a communication from superficial, meaning closer to the surface, to deep veins, all right? Because everything's superficial. The artery system, the bigger arteries, go into smaller arteries, same thing. You have your superficial, they're smaller, they're gonna go into our deep arteries to get into our systemic circulation back to the vena cava. So these ones, superficial, usually somewhere in the subcutaneous layer or just below of the skin. Deeper ones are gonna run through the muscles. Okay. And then again, perforating or penetrating, you'll see as both. Upper limbs, this is where your vascularity comes in, guys. Superficial veins are bigger and more easily seen, okay? So superficial veins in the upper extremity look like that. In the lower extremity, the deep veins are much more prevalent. And again, I've mentioned it multiple times. Does it make sense that in the lower extremity we need that gravitational assist, if you will? So we need the muscular pump more so than we do in the upper limbs. Does that make sense, everybody? Which is why your lower extremity veins are deeper rather than your upper extremity veins on the average. Okay. So that's why you can't get nearly as vascular in your lower legs. Those are holdovers. Terry loved those pictures for some reason, but not much of a laugh here. So veins, why remember, anybody ever think when you were a kid that your venous blood was blue and your arterial blood was red? Blue-blooded American, you've heard that before, right? Well, the reason why your veins look blue is because of the red light doesn't pass easily through your skin, so it looks blue. Right? Now you all know that. Tell your kids. You guys not having it today, huh? You guys all right? Huh? Not today? All right, varicose veins. Talked about those. So when we get, everybody knows about these ones, the superficial veins of the lower limbs, but varicosities, those are probably like the least circumstantial when you talk about clinical physiology or pathophysiology. They're ugly looking, and to a certain extent they can cause some edema and some additional problems, especially like I said, if you're more bedbound or something like that, like you were discussing, it can cause more problems. But probably of consequence, the most consequential varicose veins are actually in the esophagus when you get them. There's esophageal varices. Most of the time having to do with a chronic alcohol problem and then increased pressure within the liver. So you get an increased pressure within the liver, you get a back pressure in that portal system that we were just discussing, and then what you get is a engorgement of the vessels surrounding the esophagus. And they can bleed. High mortality associated with that. Does everyone know there's between morbidity and mortality? So morbidity is bad outcomes, mortality is death from, okay? So these can bleed liters of blood. Like if you have somebody who has sufficient enough esophageal varices, they can't lose their enough blood volume to die if they're not tamponaded soon enough. And not that you know this already, but if you put together somebody who has chronic liver problems, one of the other functions of the liver is to make clotting factor. So if you have a liver that's half dead anyway, and then you start bleeding, not only are you gonna you're not gonna clot, you're not gonna be able to clot because you don't have the clotting factors anymore because of your liver. Somebody move this, please. And then, and so that's why the mortality is pretty high with that population. Okay? Alcohol isn't the only reason for it, but it's one of the main ones. And then, of course, we have our old friends, hemorrhoids. So, varicosities of the anal canal, very common, of course. Clinically, you know, when I want to say primary care relevancy, I'm sure you guys will see a lot more hemorrhoids than you do esophageal varices. So, as far as like practicality of everyday clinical life, you guys will have to get more comfortable with hemorrhoids than esophageal varices, I hope. All right. So, this is another thing. If you have that blood pooling and a lack of blood flow, phlebitis is an inflammation or infection of the vessel itself. All right. It can also happen if you get a bad stick. You know, if you have somebody who's not great with their sterile or aseptic technique with a IV, you can get a little redness around there, some phlebitis when it gets a little angry. But that does happen when you have a lack of flow, which is a lack of energy and waste, or lack of waste removal, if you will. And then I think I just need to put the muscle pump stuff earlier. That's the answer. Why do the superficial veins? Because the deep veins are running through that musculature, so they get the assist of the muscles pumping and the muscular contraction and relaxation. That actually helps propel that blood forward more so than the superficial veins do, right? So just a couple of things treatment-wise. Elastic compression stockings sort of help Band-Aid treatment, not necessarily, they're more symptomatic care than anything. It helps prevent that edema because they sort of act as a secondary supplement, like a buttress to help keep that fluid moving up. Sclerotherapy, for those of you who don't know, is actually sclerosing or closing off the smaller veins, all right, or some of the larger ones, depending on the level of varicosities that exist. Laser occlusion is the same thing, sort of like killing an area of that vessel. And then venous stripping, if they have sufficiently bad enough varicose veins, they'll just actually go out, pull them, right? And then blood communicates into the deeper veins. And so you still have blood flow, you still have venous return, it's just they're getting rid of those incompetent ones on the surface. So little gee whiz stuff for you there. And here's a picture of hemorrhoids. Esophageal varices, honestly, if you look at them, that esophagus, the lumen of that esophagus should be probably twice that size. So those huge vessels protruding in here, when these start to strip open, like this is one big varicose vein right here. And like all of this super wavy, those are all varicose veins. So when those start to bleed in somebody who has significant pathology and coagulopathy, it's bad news. Yes?
With the varicose veins, can you also flush them out?
Can you flush them out?
Yeah, in your process, like where you unclog it, unflush it, get rid of it.
You can, but that's sclerotherapy really. I mean, you can't flush them out, so to speak, because the vessel itself is incompetent. So with sclerosis, you inject a sclerosing agent into it, and it closes it down. That may be what you're talking about. Yeah. And then this is an example of a thrombosed external hemorrhoid. Extremely painful just because of the anoderm tissue, very sensitive nerve tissue, innervated nerve tissue. So we'll talk about internal versus external hemorrhoids later. But that's an example of the venous stripping. So same person, same leg. Just gotta pull those big ugly veins out of there. And sometimes it's just hereditary. There is a genetic component to it. Sometimes people just have these despite being excellent health otherwise. So it's not a function necessarily of having a sedentary lifestyle or anything like that. It's just some people are more predisposed to them than others. Okay. Not that being sedentary doesn't help contribute. Okay. You guys good?
Yeah, question.
Yes, sir.
Sir, are there any negative outcomes, I guess, or things that can happen if they end up doing the venous stripping since they're removing those veins from?
Negative. I mean, yeah. No, I see what you're saying. Those as ugly and as large as they are, right? the deep veins are still in there, are more than capable of picking up the slack of the circulation and the venous return. So no, does it cause like a stasis problem? If anything, it alleviates it because you have less blood pooling in these, less blood pooling in these sort of these corollary circulations where it's just sitting there. So actually, after something like that, most of the time the patient has significantly less lower leg pain, significantly less edema. So I can see the thought process is there because you're taking out these vessels, how is the blood getting back? It's still getting back in those larger deep veins. Yeah. Does that make sense? Do we need like a 5-minute refresh? Or are we gonna keep going? We don't have that much more to do today, honestly.
Try Mike.
I have a question.
Okay.
When it comes to like drug users and tracking, what is happening to those veins that leads to the tracking?
Inflammation, infection, phlebitis, chronic phlebitis. Yeah. Especially if you're, when you're using, dirty needles. Do you remember us talking about bacterial endocarditis?
Yeah.
Real briefly in the first. That's the kind of what happens. You'll be injecting, bacteria, what have you, into the veins. It makes its way into the heart and it sets up those vegetations. But on the way, while you're getting that chronic redness, is chronic phlebitis, inflammation of the vessel itself, infection of the vessel itself. Yeah. Anybody else? Okay. So anastomosis and collateral circulation, we've talked about these before, right? In what capacity? Where did we talk about these before? You remember? Heart, yeah. What's specific coronary circulation? Talked about sometimes we have blockages within the coronary circulation, even if they're not complete blockages. And so we have growth of new vessels around that blockage. What is the growth of new vessels called, everybody? Angiogenesis. Okay? So angiogenesis is the process by which new vessels grow. Anastomosis is what the thing is that grows. Does that make sense? And anastomosis is a connection between vessels. Okay? There are pathologic. If anybody's ever heard of an AV fistula, anything with the word fistula in it is usually pathologic. Okay? A fistula is an anomalous connection. So something that shouldn't be connected to something else becomes connected to something else. All right? So you can get fistulization from, if you have like a very serious inflammatory bowel disease, you get fistulization from one part of the bowel to another, from the bowel to the skin. In this case, we're talking about a direct connection between a larger artery and a larger vein without all that stuff in the middle. So you have that fistulization. A lot of times it will happen in the brain, okay, AV fistula. And if they have a real potential to aneurysm and blow. Because there's too much pressure there. There's too much pressure going directly to the venous side from the arterial side. It hasn't flown through all those smaller vessels that will sort of absorb some of that pressure. So a lot of times they have a real problem with aneurysm, which if you don't know what aneurysm is, it's basically like a goose egg in a balloon, right? Just the balloon swells and pops sometimes and then cause for a stroke, hemorrhagic stroke. That's a lot more than you needed to know, but there it is. So there you go. That's just, you have an occlusion. The body still wants to perfuse that area, still needs to perfuse that area. So we create these little corollaries, these little anastomoses, collateral circulation to just basically go around it. Okay? A lot of times when you get to your ophthalmology class, one of the easiest places to see something like this is your retina. When you have a patient with chronic hypertension or chronic diabetes, you get what's called a proliferative retinopathy. So you look at the back of their retina, and instead of the normal number of vessels and veins, things just blown out with vessels everywhere. Because neovascularization, angiogenesis is occurring. You got all these, and think about the size of the vessels on the retina, right? Very small. So a little occlusion. Now you need to perfuse so you can still see, right? So you have all of these vessels that are growing every which way. Right? Yes.
Can it happen more than once at the same site?
Yeah. Yeah.
If the primary route happens to open back up, does it do anything as far
Do the corollaries close? Yeah, that's a great question. I don't think so, but I'm just guessing. I don't think they would, because, I mean, They might scar down after, if you revascularize something, they might scar down because they're getting a lack of blood flow through them because the main thoroughfare is back open. But I really don't know if they close or not. I don't think so, but I'll have to look that one up. Good question. Yeah. Anybody else? Okay. So, blood distribution. Right. We're gonna move a little bit into physiology now, a little bit. But that's the anatomy. The anatomy stuff makes sense. Okay. All right. So again, even though it may seem counterintuitive, where most of our blood is in systemic veins and venules, right? Capacity. We talked about there being a reservoir. All right. That's where most of our blood capacity is. So you see, capacitance vessels. Not as much as you would probably think, and the least amount is in the heart, right? So at any given time. And why? Just conceptually, somebody tell me why. Why isn't there most of the blood sitting in the heart? Is it really doing anything when it's in the heart? No. It's just the heart is the pump. The heart's only job is to pump that blood out so that it can go out and do the stuff it needs to do. Right? There's no real there's no real energy exchange, there's no nutrient pickup. The heart is just a pool pump, right? And so you don't need the blood sitting there, right? So you go more useful tissue. Pulmonary blood vessels, well, we need it to be more there in the heart because that's where it's picking up oxygen and delivering carbon dioxide, you know. And we have systemic arteries and arterioles, which are our distributing vessels, right? Our conducting and distributing vessels. So, anyway, that's enough on that slide. And here is a picture of that slide for those of you who have pictures.
That's what you
Here's another picture of this slide. It's a different way, but let's look at this one conceptually. I like this one a little bit, right? So, 25% of our blood at rest, what organs are getting perfused? The liver, right? 20% kidney, all right, that makes sense. Brain, 15%, more or less for some of you. And then muscle, 20%. Why? Why these tissues? Why this distribution at rest?
Is it metabolically green?
Yeah.
Or they have an important
Because they are metabolically active even at rest, right? So your brain isn't going to change blood flow between exercise and rest much. All right, much. Your brain's going to be pretty steady receiving blood because obviously that's what we need to be alive. So it needs to remain perfused. The liver and the kidney, what are they involved in? Blood filtration, right? That's all you need to know. Blood filtration. So they are metabolically active. They are having the blood delivered to them to get rid of waste products and to deliver some nutrient, if you're talking about the liver, right? So we need them to have blood flowing through them. What else is the kidney involved in? It's involved in systemic vascular resistance. So we need perfusion going through those things. And then muscle, because whether you're at rest or not, your muscles are still metabolically active tissue, right? And so the rest of the stuff gets a little bit less. Then when you go to maximal vasodilation, meaning we're exercising, these guys get real greedy, right? Right? We don't need to be digesting the food while we're running, right? We need to be able to run away from the tiger, all right? So, does that make sense?
Question for you, on
Yeah.
the previous slide, so the intestines, at maximum flow, like, if that's not rest, what is maximum flow of intestines? Is that not like?
It is rest.
Rest and digest?
It is rest to digest. And it'll go up, like, so for example, the intestines after a meal, that distribution is going to change a little bit to increase to the intestines. But the point is, like at rest, still kind of sitting there, maximum blood flow, if you will. But when everything goes up. Like everything goes up when you're at maximum flow at exercise. But we still need most of the blood in the muscles and the skeletal tissue, to be honest. So. Yeah, that's right. Kale, not so much. Taco Bell, everything goes down, especially blood flow to the brain. All right, we're almost done, you guys. Capillary exchange. Now, physiology, the function. Why is this blood moving around? What's it doing when it gets there? All right. 3 mechanisms and differences in how they occur. Because know what diffusion is. Is that a passive or an active process, really? In general, it's a passive process. We have more stuff on this side, it's gonna go to this area of less stuff. So, before we even get there, oxygenated blood has more oxygen than the tissue it's delivering it to. Where's the oxygen gonna go? To the tissue, to the area of less stuff. The area of the tissue has more carbon dioxide waste product in it than the oxygenated blood does. Which way is the carbon dioxide gonna go? Back into the blood, right? That's diffusion, simply put, all right? Transcytosis, we're gonna end there. That is simple, it's just movement of like stuff, like specific stuff into or out of the cell, where it's basically like gonna grab it or it's gonna spit it out. We'll get there. And then bulk flow we're gonna start with tomorrow, because that's where we start talking about different kinds of perfusion pressures and it gets a little sticky, all right? Not really, but it's just a lot. So diffusion, higher concentration to lower concentration across a concentration gradient, right? Slower process relatively than the bulk flow that we'll discuss, because bulk flow is more of an active process, so it pushes a lot more stuff out at a higher speed, if you will, or collects more stuff at a higher speed, you know. But the easiest one on the diffusion side of the house again is oxygen and CO2 exchange. Brain capillaries, continuous capillaries. Anybody ever heard of the blood-brain barrier? All right. So we want to sort of highly regulate the stuff that gets into our cerebrospinal fluid. So there is a blood-brain barrier, tighter junctions within the capillaries that we get there. And basically, again, it's this. It's a semi-permeable, more selective membrane that's packed tighter so that things don't freely cross. Okay? And then you have certain areas, this will become more apparent in our endocrine side, we talk about the distribution of hormones. Alright, so some areas don't have a blood-brain barrier so that those hormones can move more freely across. Fine point right now, just understand that in isolation, okay? But if you look, most capillaries in the body, and we know that most capillaries in the body are continuous capillaries, right? So continuous, then we have fenestrated, then we have sinusoidal. Continuous are the most common, most prevalent. Even within that subtype, there is a difference because the brain capillaries are continuous capillaries. They just have tighter junctions. And that versus that is a blood-brain barrier. Does that make sense to everybody? So what is that thing called? What is this little gap called here? Intercellular clefts, right? Intercellular junctions, right? So those are closed tighter, and that's a blood-brain barrier. Can stuff still move through there? Yes, 100%. Of course, because we're alive. So our blood is getting to our brain, and our brain is getting stuff, and then getting rid of other stuff. But just understand the fine point right now that that is the structure of most of the capillaries in the brain. Okay.
You say it was continuous but tighter?
Yep, so it is a continuous capillary, right? It's just that the spaces between the individual cells, I mean, this is, again, artist rendering of it, but versus a normal gap you would have, say, in your muscle tissue, you have a much tighter gap, so that the stuff that can get into your neuron is more tightly regulated, okay? And then we're gonna finish up here with transcytosis, okay? Everybody understand that? The blood-brain barrier stuff. Okay. Transcytosis, what does it sound like? What does it sound like? What does transcytosis mean? Something moving cells, something, right? Moving in a cell, that's what it is. It's something moving into or out of a cell. We talk about endocytosis. It's the cell grabbing something and bringing it in. Exocytosis is the cell throwing something out of it. All right? So in the process of endocytosis, a lot of times what happens is that there is some sort of receptor on the outside of the cell membrane. Something comes attached to it, the cell membrane grabs it, makes a vesicle and brings it inside, okay? Opposite of that is exocytosis. Let's say it's a waste product, or let's say it's something that that cell produces that it has to send out into circulation. A vesicle forms around it, it goes up to the cell membrane, it opens, and it kicks it out. So endocytosis is bringing it in, exocytosis is bringing it out. Is that clear enough? Okay. And here's a picture. Right? So a lot of times what this thing is missing, there'll be a little receptor guy here. This little gray ball will connect to it, and then the cell wall or the cell membrane, just swallows it up into a vesicle. And on the other side, this guy made something, it has to get out, it connects with the cell membrane and opens up and spits it out. So, endocytosis and exocytosis. Okay? All right, you guys. What do you think? Okay.
So transcytosis is not a combination of endo and exo?
It's the overall process, transcytosis. Something moving into or out of the cell. So yeah, it's the overall heading, subheading, is it going in, going out, yeah. And then we're gonna talk about other ones too that go between cells and stuff like that, but.
So you can have a combination of two, like one
Yes.
at the same time.
Yeah, because you can have a cell that's making something, let's say an endocrine cell that's making something to spit out, and also has to take nutrients or something in, so yeah, absolutely. Sometimes it's a signal for that cell to make its thing, so that's endocytosis, and it makes this thing, and then an exocytosis is whatever it made out, so yeah. Huh? Oh, okay. So what do you think, everybody? Yeah, Charlie, that's right, good job. Right, so the iliacs are still a conducting vessel, then they go into the femorals, and then that becomes undistributed, alright? Does anybody remember which one would not on the list that affect vasomotion? Sodium, that's right. Because oxygen on the oxygen side, obviously, and then you have carbon dioxide, hypercapnia, then you have too much lactic acid, and you have too much carbon dioxide, and too much lactic acid, and you have too much acid. So we waste products. Sodium doesn't have an effect on vasomotion. All right, what is vasomotion? The opening and closing of the precapillary sphincters, right? Kind of moving that blood vessel along, propelling it along. All right, you all. That is all I have for today. And then next time we got, each of the next two will be about 50 slides worth. The next one's physiology. The very last day should be fairly easy, honestly. Tomorrow is just going to be a little bit more challenging, only because of all of the different things we have to remember as far as like net filtration pressure and these kind of pressures. But I hope I have it broken down easily for you, so we will see. But the other nice thing is that this exam is on the back side of the Memorial Day weekend. And so you guys have plenty of time to chew on it and ask questions. And I don't have any big Memorial Day plans, so I would love nothing more than to answer anatomy physiology questions on all 4 days. So, but I will happily do so. Any questions for me today? All right, y'all. Thanks.